In this video, we'll talk about psoriatic arthritis, how it presents, and how do we diagnose it in addition to management. So, psoriatic arthritis, first of all, we need to know that you have to think about this disease in a patient with psoriasis who present with joint pain. Now, the joint pain, if it's in the back or in the distal hands, in both sides, not necessarily symmetric though, and the patient mentions to you that they have stiffness in the morning, then you have to think, well, I have to work them up for psoriatic arthritis. Now, psoriasis is important, and it can present in around 85% of the time before the arthritis can start. Now, you want to examine the patient, check their nails, if they have any pitting or onycholysis, and you want to ask them about their eyes, if they have any uveitis symptoms, which include photophobia, blurry vision, and as well if they have any conjunctivitis. Now you need to also ask them about enthesitis, which is inflammation of the tendons, and the most common involved tendon is going to be the Achilles tendon. So see if they have any pain right there, or they have pain when they walk, and you can refer back to the foot pain video and see how Achilles tendinitis can look like. Now let's talk about diagnosis. So if the patient presents with psoriasis and they have typical features of the arthritis, as we talked about, back pain and distal interphalangeal joints, then that's enough for diagnosing psoriatic arthritis, and you don't need to do anything else. Now, if the patient does not have any psoriasis, then you need to look for other manifestations. We talked about the extra-articular manifestations like the enthesitis and uveitis, and you need to do an X-ray to look for the typical features of psoriatic arthritis, which includes erosions as well as the pencil and cup deformity, which we see in the interphalangeal joints, basically. You need to test for HLA-B27, and as well you need to rule out other diseases that can look like psoriatic arthritis with rheumatoid factor, CCP, and ANA. Now, let's talk about management. So, if the patient has a spinal involvement, then you can treat them with NSAIDs and TNF-alpha inhibitors. And again, not methotrexate, because methotrexate does not go to the spine. Now, if this fails, then you can try second-line medications, which are interleukin inhibitors like ustekinumab and secukinumab. If the patient has peripheral joint involvement only without spinal involvement, then you can say if they have erosions, you treat them as a spinal involvement. But if they have no erosions, then this is more mild disease. And since we are talking about peripheral joints without spinal involvement, then NSAID should help, and methotrexate can be added if we have 4 or more joints involved. Now, if that fails, then you need to know this medicine, which is called apremilast. Now, rheumatologists like it because it doesn't need any monitoring with CBC, CMP, and it has less side effects than many of the immunosuppressant medications. And this is it for psoriatic arthritis. Hope you guys learned something. See you in the next one.